Hello, I'm Richard Westerby with IV Fertility Services, and today we have the amazing Dr. Jamie Massie, who is going to talk to us about what to expect when you're starting your fertility treatment.
Thank you. I'm so excited to be here.
So, cutting straight into it, when somebody's come to you, what can they expect to see, hear, feel, do?
It feels super overwhelming. And I actually love that this is a topic because one of the primary things that actually prevents people from seeking out fertility care really at any point from the process of I'm thinking about having a baby in 10 years to we've been trying for 10 years to have a baby is fear that you are going to go to a fertility clinic and they are going to force you into a specific pathway. And so starting at the very beginning, I think demystifies it a little bit. You know a little bit about what you're going to get into. And so it doesn't feel quite so terrifying when you start. So first things first, you're going to seek out some clinics. We can talk a little bit about that if you want. Once you decide where you're going to go, you'll make an initial appointment. And that appointment usually starts in one of two ways. So some clinics have you meet with a nurse practitioner or a PA just to get some initial intake information to make sure you've got your records and that everything's in place for your visit. Other clinics have you meet directly with the physician first. And then once you've had your physician appointment, then you move in to kind of the testing and next steps pieces.
So, there's an assumption made that you have a problem here, so you're going to come and see you, right?
Not true.
Debunk that.
Yes, debunk it. So I think that as a medical community, we are really good at preemptive medical care when it comes to everything except fertility. And so one of the things that we really want to debunk is you need to seek out care early in the process, right? If you are a 20-year-old individual, whether you're a sperm provider, whether you're an egg provider, you have no idea what your reproductive health looks like in that moment or what that might mean for you in the future. And the earlier you get that information, the better. And if the information is everything looks normal, right? Then you can take a breath and I'm good for the next period of time. The issue we always run into with individuals is that if you wait too long to seek out care, then even the technologies that we have to help people build their families may not be successful. So one of the biggest myths of reproductive health is that you only seek out care when you have.
So in effect, if I just wanted to go and do a sperm test just to see if my sperm is good, I'm okay to do that.
Absolutely. 100%. Not only are you okay to do that, but we encourage people to do that. There really is knowledge, right? Knowledge is power. And so the earlier you get that information, the better.
And so do you find that within the medical community, say, for example, with OB-GYNs, like my daughter is going to start going to see an OB-GYN, do they promote that? Or is it kind of something that they just go, when you're older, or, I mean, how does that?
Yeah. Great question. I think it depends on who you're talking to, right? Just like every field of medicine, there are some people that are very passionate about different things and some people who really don't like certain things. And so I think a little bit of that is driven just by the personalities, unfortunately, of the people that you're engaging with. And so the take-home message really is, if you go to somebody and ask the questions and you're not getting a warm and welcome response, then that's not the right place for you to be. It's not that you're not asking a good question. It's not that what you want to do is not important. It's that you just haven't landed on the person who also sees the value.
I do think there's a lot of this unknown.
Yes.
You go to a doctor, you don't necessarily know the questions you need to be asked.
Absolutely.
So then how do you know which questions to ask?
Absolutely.
So if you were to say to a 22-year-old female, what questions should she be asking?
So one is, what should I be looking at in terms of my menstrual cycle? The second is, what do I need to know about how my age impacts my success rate in this moment? And what might that look like over time? And third is, what does my egg supply look like right now? So we as egg bearers, we're born with all the eggs we're ever going to have. You actually lose more eggs even before you're born than you lose through your whole reproductive lifetime, right? So, and it's a bell curve, right? So some people have no eggs left at all by the time they're 20. And some people have really good egg supplies until their early 40s. And that correlates to some degree, right, with how likely you are to be successful at building your family at any given time. And so knowing that information about you just gives you power.
Knowledge is power.
Absolutely.
The more we can empower people to know about their own bodies.
Yes. And to some degree, the information that we have may not be predictive. So, for instance, one of the tests that we really routinely do on individuals who are curious about egg supply is a hormone value called AMH, or anti-Müllerian hormone. Anti-Müllerian hormone is not a predictive indicator. So you can't look at an AMH level and say, okay, based on this AMH today, in 2 years, I'm going to be here. In 5 years, I'm going to be here. In 10 years, I'm going to be here. It gives us a snapshot in time. But at least it gives us a snapshot in time, right? If that value is really abnormal, then that might prompt you to make some decisions that build a safety net under you as you're moving forward in your family building.
Also, if you have that snapshot in time every 2 years, you can build a picture of you over the period of time that you're doing.
You got it.
It just blows my mind that we don't do more of this testing.
Okay, I agree. Yep.
So somebody's come into you,
Yep.
say, for example, they've come to you, they want to do a routine test, and all of a sudden you're like, hey, something's abnormal here.
Mhm.
What then?
Yeah. It depends on where you are. So part of our job is to figure out, to meet you where you are, right? So the answer is going to be different if you're a single individual in their late 20s. It might be a different thing if you're partnered and you're in your late 40s, right? For younger individuals who are not ready to build their families, that might be talking about things like sperm preservation or egg freezing. For people who are thinking, in the next 6 months, in the next 12 months, I'm really going to start wanting to grow my family, that might be talking about treatment options that are available to you sooner rather than later. I say to people a lot the same thing. So when you talk about the definition of infertility, right? So if it's somebody who's having regular menstrual cycles, who's under the age of 35, who has regular exposure to sperm, you're considered infertile after 12 months. If the egg provider is over the age of 35, that window drops to 6 months. But that does not mean that you have to wait that period of time to get care. Because the same thing that makes you infertile at 12 months also makes you infertile at 2.
Right. So you don't have to wait that 12 months. You can go, there's something happening now.
Yes.
Can we please look at it and figure it out?
Yes, absolutely. Absolutely.
And then to do sperm preservation and egg preservation, do you have to have a partner?
Absolutely not.
Okay, so you can do that irrespective of where you are in your period of life.
Absolutely.
And does that guarantee you a baby?
No. So no guarantees in life, right? And that rings true even for fertility care. So there's no number of vial of sperm that's going to guarantee that you'll be able to create healthy embryos. There's no number of eggs that you can have in inventory that's going to guarantee you a live birth. So I like to refer to them as safety nets, right? It's something that's underneath you just in case. The hope is honestly that you won't need them, right? But they're there as a safety net just in case.
So I've come to you, something's abnormal. My dream of 2.4 children, white pants, that's just rumbling in front of me.
Yeah.
How do you help those people from an emotional perspective, from a physical perspective, and the steps in the process?
Absolutely. So the first part we've touched on a lot, which is just testing, right? We have to figure out what's going on and why you're struggling. And when you look at statistics, we know that about 25% of infertility is caused by sperm-related factors, about 25% by egg uterine-related factors. There's a big chunk, about 25% that are unexplained, that we don't know, even after we do a full evaluation, and about a quarter of a mix of each. So first step is to look at each of those systems of the reproductive system and say, what are we missing? What's going right and what's going wrong? So for sperm providers, that's usually a semen analysis. So just looking at an ejaculated sample of sperm under the microscope. Are they swimming? Are they normally shaped? Are they there?
Even there. And can that be done? Because, I remember I did a sperm test and I'd never done one before. And it was in the clinic and it was super scary. And I was just, for me, it was very overwhelming.
Absolutely.
Can that be done at home? Can it, does it, how can you make it let men are wimps, right? We're not great at doing that. How can it be easier for the guy to get that part?
Absolutely. So one, I think, is to recognize that you're not alone, right? That I always tell people it's weird for you, but it's normal for us, right? It's something that happens every single day at our clinic, time and time again. So just to sort of normalize it is just a normal test. It's like getting your blood drawn, right? The second is that most clinics have in place the option to collect at home and bring the sample in. Now, that is limited a little bit in terms of where you're located, because sperm motility in particular goes down over long periods of time that it's not kept at a certain temperature. And so we generally say you need to live within, an hour of the clinic in order to get a sperm sample there. But what I would encourage everybody, and this is true not just for sperm collection, but really at any part of the process, is voice your angst. Our job is to get you through it. Our job is to say, okay, this is a really scary moment for this individual. These are the things that we can do in order to minimize that anxiety and fear. And this is such an emotional process at every single step. As you've been right, it is. And you think, oh, if I just get to this place, it'll be okay. If I just get to this place, it'll be okay. But it remains scary throughout the whole thing. And the most important thing that you can do is advocate for yourself and vocalize what makes you nervous. What are you scared of? What are you worried about? Because 99% of the time, we as a team can come up with something to help make it easier for you.
In my head, if I go to a clinic, I'm in a room, there are people outside, there are people walking past, there are photocopy machines. Like, that's not conducive potentially to getting to the point where I can ejaculate.
Sure.
If I do it at home, how does that work? Do I do it in a cup pot?
Yeah.
Backseat
of your car. Yeah, what happens? Yeah. Yeah. So we generally send people home with a collection kit. It will have instructions, things like don't use a lubricant, right? Lubricants can impair sperm motility. And so that can give you a falsely negative result. It'll tell you window of abstinence, right? We want the window of abstinence to be actually pretty short. There's this idea that, oh my gosh, I'm going to do this. I need to save up. And that actually makes the sperm look artificially bad. So we don't want to do that. So it'll give you those instructions. And then usually there's a cup that you collect the sample into. It comes in a bag. So it's not like your urine sample that you ride up the elevator with. Nope, it's in a bag so that it's completely hidden. You will label it at home. Remember that when you come to drop off your sample, you have to bring your photo ID with you. It's like police chain of collection in the clinic. Yeah.
Fine. So you're making it a little bit less scary,
yes,
which is great.
That's the goal.
Perfect. So then how do you, from this, obviously I can talk to the male perspective, but from the female perspective, there's going to be a lot more involvement, physical involvement.
Yeah.
Like, how does that work? And how do you make that less daunting?
So 3 components really to the, the female reproductive system evaluation. So ultrasound, which is a vaginal ultrasound.
So not on the belly.
Not on the belly, not like you see on TV, right? It's a long, thin ultrasound wand that's placed in the vagina. We do that not to torture people, but because it gives us the most accurate views of the uterus and the ovaries. Blood work, so blood draw. And then we usually do what's called a uterine cavity evaluation. So when you look at the uterus on ultrasound, the 2 walls literally lay on top of one another, kind of like a peanut butter and jelly sandwich.
So it's not like it looks in the biology books.
It's not like that.
Right.
And so there's a couple of things we can't tell when we look at the uterus on ultrasound. We can't tell the shape of the uterus, and we can't tell if there's anything pushing in to what we call the uterine cavity, which is the place where the embryo actually implants and grows, that might inhibit a healthy embryo from growing, from implanting and growing. In order to see that, we have to put fluid into the uterus and push those walls away from one another. So it's generally done in one of 2 ways, with a study called an SIS, or saline infusion sonohystogram, or a study called an HSG, which is a hysterosalpingogram. One is an ultrasound-based water test, one is an X-ray based test.
And excuse me for being ignorant, but do you just push water in and then it expands and then they pee it out?
Great question. Great question. So the way I like to explain it, because people usually are familiar with a pap smear screen. So the study always starts sort of like a pap smear, where we place a speculum in the vagina, we clean the cervix with an antiseptic solution, and then we use a little catheter. It's about the size of a tip of a pen. Place that just inside the uterus, and then we fill up the uterus either with water, in the case of an SIS, or with dye that you can see on X-ray in the case of an HSG.
And then what happens?
And then we take pictures. Okay. So we either take ultrasound-based pictures, or in the case of an HSG, we take X-ray pictures. That part is crampy. I do tell people this is the meanest thing that we do to you, honestly, from a reproductive evaluation standpoint. Our clinic, PNWF, we actually have the option to use laughing gas or nitrous during these procedures, which has been wonderful for people. They're much more comfortable during the procedure. It makes it so much less scary when you're not worried about how you're going to feel during the procedure. So that's a really nice option that you can ask about in your clinic.
And then there's a toilet next door.
And then there's a toilet next door, but your body actually absorbs all that water. So a lot of it goes out the fallopian tubes and into the abdomen if the fallopian tubes are open. And some of it just gets reabsorbed and some of it comes back out the vagina as soon as we finish the test.
If a woman is coming in to do this, do they need to shave, clean? Like you're looking at their most like.
I know. The reason I love this question so much is because I think honestly that people get more prepared for visits with me than they do like when they go on a date or out with their partner. We all, and complete transparently, honestly, we really don't care. Like I honestly notice people's cute socks more than I notice anything else. So no, you don't. You just show up and
because those stuff. These are the little things that
they are.
I'm like, yeah, you're looking at uterus, but does it?
I totally know you mean, which is why I think people put so much time and effort into getting ready. But you know what? This family building takes a lot of time and you don't have to spend one extra minute.
And if you're doing it, do you keep your clothes on? Do you take your clothes off? I mean, obviously you can have to take something off because you're going in.
Absolutely. Right? So for the x-ray based studies like HSG, we usually have people put a gown on top and then take bottoms off. For ultrasound-based evaluations, you remain completely clothed up top and you just take underwear and bottoms.
So don't wear a romper suit.
No, that's a summer problem. If you wore a romper, we have plenty of gowns in the clinic, but you.
And can people have a chaperone?
They may, always. Yeah, you can always bring a partner, a friend, a support person, never have to be alone.
Because that, again, to me, it feels very invasive.
It is invasive. It doesn't feel that way. It is invasive. And so we always want people to have whoever they feel like needs to be there to support them, to support.
So they've done all of this. They then get their results and it's X, Y, or Z that's not working.
Right.
And then what happens?
Yeah. So then we have a really honest conversation about what options are open to you and what those success rates might look like based on your own circumstance. And for most people, there's not just one answer, right? There's a broad spectrum of things that we can do to help people build their families. Things as simple as oral medicines that help you ovulate more regularly, to intrauterine insemination or IUI, where we're just putting sperm directly into the uterus when we know that the egg will be there, all the way to things like IVF and collaborative family building through sperm donors and egg donors and gestational surrogates.
And I guess kind of going back, who is the person doing all of the testing? So a patient comes to you and you are the one that sees them every appointment?
Great question. Yeah. So this too is a little bit variable depending on what type of a clinic you go to. So there are some clinics that are just a physician and their support staff. And in those circumstances, which honestly are becoming more and more rare just because of the intensity of what we do, that individual sees you for all of your visits. I would say the more common model, and the model that we have at PNWF, is I am your physician. I know your story. I make the decisions with you about your care, and I see you as much as I can. But at the same time, we want to make it fit your life. So we have other physicians, we have nurse practitioners and PAs who can do things like SISs and HSGs and ultrasounds, so that we really open up the umbrellas of time that are available so that it works for your schedule.
Okay. So then I guess the question is, do you have to have different levels of qualifications for doing different parts of the procedure? Because if I'm coming in to see you and you're my doctor, and I'm expecting you to be the one to be doing my egg retrieval, my whatever it is, I mean, how does that work?
It's an excellent question. So I think let's start just by kind of explaining what I did to get my title, which is reproductive endocrinology and infertility specialist, which is that I went to college, then I went to 4 years of medical school, then I did 4 years of residency in obstetrics and gynecology, I got board certified in OB-GYN, and I did a 3-year fellowship in infertility and then got board certified. But there's also a lot of nuance, and there's a lot of stuff that can get missed if you're not working with somebody who really knows what those warning signs are and what to look for. So that's what we do. But we also have huge teams that work with us. We have nurse practitioners and PAs, right? So a physician assistant or a nurse practitioner. They also do training after college in order to get those certifications. They also do testing to confirm that they are qualified to do what they're doing. And then they usually get on the job training in the field in which they are specializing. So we train them to do the components of the evaluations that we want them to do. And they're brilliant at it. They're wonderful. Our nurse practitioners and our PAs are an integral part of our team, and it would be impossible for our team to work without them. And then we have a whole group of people who's doing things like helping to coordinate your care, answering those day-to-day questions that you have. And that's a combination of both registered nurses and people who are just very interested and smart in the field that we train to support you. So there's really like this big infrastructure there to really guide you and support you at each piece.
And each one of those people is there to support.
At every level, You know, it's really important, at least for me as a physician, that I know that my patients are getting questions answered in a timely way, that they never feel lost or alone in the process, and that their questions are being addressed at the appropriate level, right? Not every question you have needs to be answered by a physician. It should be answered by somebody who can get you the right answer quickly, right? It's silly for you to wait for 2 days to hear from a phone call from me when it's something that could be answered on the spot by somebody else. But at the same time, I always want the appropriate things.
And I think this is really helping me to understand how it's daunting, it's scary. We understand that. We are here to support you.
And it's a whole new language. You know, my husband is a pilot and he says things all the time. And I'm like, I have absolutely no idea what you just said to me, right? And I don't have to understand what he does in order to get on a plane and to go from point A to point B. But my patients need to know what I'm saying in order to get from point A to point B. And so ask a lot of questions, right? If something's said to you, don't understand, clarify what that is. And if you feel like you're not getting the attention that you need, then either escalate it within your clinic, right? Or seek out other places. You know, every clinic sort of got its own personality and its own system, and one size doesn't fit all, you know?
I love that. Thank you so much.
It's been super fun.